Good evening. I'm Dr. Gautam Ray. I'm a consultant pediatric gastroenterologist at this hospital at the Bhagirathi Neotia Women and Child Care Center at Newtown. So today we'll be talking about foreign bodies in children. So what are foreign bodies? Actually, anything which the child may ingest is called a foreign body. Anything which is outside the body and which the child may accidentally ingest is called a foreign body. It is actually quite a common problem in children, and the age at which foreign body ingestion is seen in children is generally from the age of about 6 months to 3 years of age. So this is the time when the child is exploring the world. Whatever he does, he takes it and he experiments with it and he puts it into the mouth. So this is often a common problem. It is a common scenario. Now, what all do children put inside the mouth? And if he manages to throw it out, or if we as parents manage to take it out, then fine. But most often it goes inside, and that is when we need specialist opinion. So what do children ingest? Children ingest a variety of things, the most common being coins. So coins as the foreign body is the most common thing. So apart from coins, often children ingest with these days when now that electronic toys have become quite cheap and quite available. So button batteries, those button batteries, children often, that is like, they find it quite interesting, small round things, and they'll put it into their mouth and accidentally they will ingest it. So children accidentally ingest coins, they ingest button batteries, they ingest buttons, they ingest pins, safety pins, they ingest anything from toothpicks. Then obviously slightly older children, food boluses, fish bones, all these often get stuck in the food pipe or in the pharynx. Then they ingest multiple, like we have seen multiple variety of things such as screws, nuts, even the plectrum of guitars, dental prosthesis, and the list is endless basically. So what to do? As a parent, obviously it becomes quite frightening, but let me tell you, often it is not a cause for alarm. So today my job is to tell you what to do, when to come to an hospital, when to come to an emergency department, and whether we can postpone the visit to the doctor to the next morning. So where do the gastrointestinal tract consists? Basically, it starts at the mouth and it ends at the anus. So there are 5 major places where these foreign bodies get impacted. So impaction is what? Impaction is the foreign body. Generally, these foreign bodies, they pass through, but impaction means they get stuck. So the most common, the 3 sites, there are 3 sites in the esophagus. The esophagus is the food pipe, as we know. So in the upper part of the esophagus, in the mid esophagus, and the lower part of the esophagus, where the esophagus becomes continuous with the stomach, these are 3 sites where foreign bodies commonly get impacted or lodged, and they do not move beyond. If a foreign body moves beyond the esophagus, then most foreign bodies pass through the stomach, they pass through the intestine, and they come out in the stool. But there are 2 other sites where they might get impacted. That is the pylorus. What is the pylorus? Pylorus is the last part of the stomach from where the small intestine starts. So that is a narrowing. That is where foreign bodies which have passed beyond the esophagus, gone into the stomach, may get stuck at this pylorus. That is the last part of the stomach. If foreign bodies manage to pass the stomach also, then the last part where they may get impacted is the IC valve or the ileocecal valve. What is that? That is the anatomical area where the small bowel becomes continuous with the large bowel. The small intestine becomes continuous with the large intestine, what we call the colon. So that anatomical area is called the ileocecal valve, and rarely a foreign body may get impacted over there. Now, you will be surprised to know that in various series data that we have from literature, often as many as 40% of foreign body ingestions were not witnessed. That is, the child has ingested, the parents or the caregivers have not seen, or do not know that this has happened. And in all more than in 50% or more than 50% of foreign body ingestions, the children are asymptomatic and the foreign body passes into the stool and it comes out. So if everything is so rosy, then why is it that we often come at night to this hospital to bring out foreign bodies? Well, there are some situations where we need emergency removal. So the most important, what we told, is that the incidence of button battery ingestion is slightly going up because all these Chinese toys in the market and everything has become so cheap. So these button batteries are very dangerous because once they come in contact with the mucosa, there is release of alkali and this causes a mucosal burn. So a button battery, in fact, a reaction may start within 2 to 4 hours of ingestion. So if a history of a button battery ingestion is there, then the child needs to be brought to the emergency and emergency endoscopic removal needs to be done. Well, what is the next thing? The next thing, so these are called high risk foreign bodies. What are high risk foreign bodies? Number one, as we discussed, is a button battery. Number two, magnets. If a child ingests a magnet, multiple magnets or a magnet attached with another a steel object or a toy or whatever. Now, often we don't realize from the x-rays whether it's a single magnet or whether they are two magnets because they often stick together and they look as if they are a single magnet. So if there is a history of ingestion of a toy magnet, often children play with these magnets. They find this quite interesting and they put it in their mouth and swallow it accidentally. So if there is a history of ingestion of a magnet, then that is again a high risk foreign body and you need to bring your child to the emergency and it needs a endoscopic removal. What are other high risk foreign bodies? Other high risk foreign bodies are large foreign bodies. So what literature says is that generally if it is the foreign body is longer than 6 centimeters or it is wider than about 2.5 to 3 centimeters, that is unlikely to pass beyond the esophagus or that is unlikely to pass beyond the pylorus, which is the last part of the stomach as we discussed, and that may cause complications later, so that also needs to be taken out. See, again, if there are symptoms, most children are asymptomatic, but if the child is symptomatic, then again you need to bring the child to the emergency or you need urgent medical care. And what is the treatment? The treatment is then removal. So what would be the symptoms in a child who has ingested a foreign body? We should keep in mind, parents as well as doctors need to keep it in mind that many foreign body ingestions are not witnessed. So we don't know that the children has taken it inside. So if there is an unexplained cough, if there is an unexplained pneumonia, if there is stridor, if there is continuous vomiting, if there is drooling of saliva from the mouth, if the child cannot eat, he is continuously vomiting, if he complains of chest pain, if he complains of abdominal pain. So all these are examples that this is a foreign body. This might be a foreign body. If common things are ruled out, such as a viral infection, or the child has been treated for a pneumonia and not responding to antibiotics, then we need to take a proper history. We need to do x-rays, which are often done if respiratory symptoms are there or upper chest symptoms are there or upper abdominal symptoms are there. Then we look for a foreign body. Then if the foreign body is impacted in the esophagus, we need to take it out. If the foreign body has passed into the stomach, so what we said earlier is that most such foreign bodies pass into the intestine and they pass down. Rarely there might be complications. So what are the complications? So we have had such a child who had ingested a pin and the parents did not know. He came for a routine follow-up to the pediatric surgeon who did an x-ray and found a pin in the intestine. And then we saw the patient and we got a repeat x-ray. The child was asymptomatic. There was no problem in the child except that there was a small swelling which was developing in the stomach. There was no fever, no pain abdomen. So we got serial x-rays to see whether the foreign body is moving. That is what we generally do when the child is asymptomatic, when the child has no problems, but there is a history of foreign body ingestion, or we find the foreign body on an X-ray and the child is asymptomatic, we do serial X-rays to see whether the foreign body is moving. In this particular child that I was telling you about, the foreign body was not moving, and actually it was a pin which had perforated the small bowel. So talking of complications, how to find them out. So complications which might affect the stomach, maybe an obstruction. Suppose it's a large foreign body which has somehow passed into the stomach and it gets stuck in the pylorus, which is the last part of the stomach. So slowly the child will start vomiting, may have features of obstruction. If it is sharp foreign body which has passed into, suppose, a pin or something which has passed into the intestine, most of it passes down. But if the child complains of abdominal pain, if the child has fever, if the child looks sick, then we know that this child has a complication. Then it needs to be taken out. What do we do? Okay, so let's start from beginning to the end. Suppose there's a child who has taken a foreign body. So if it's a high risk foreign body, if it's a magnet, or if it's a button battery, or if it is a large coin which is impacted in the esophagus, please bring your child. We will remove it endoscopically if it is lodged in the esophagus. Somehow, if it has managed, or the food pipe, somehow if it has managed to cross the esophagus and it is now in the stomach and the child is symptomatic, then we do an endoscopy and bring it out. Suppose it is in the stomach but the child is not symptomatic, then we wait for maybe 6 hours, 8 hours, 12 hours. If the child is absolutely asymptomatic, no problem, no fever, no vomiting, playing about, then we may not admit the child also. We will repeat an X-ray after 12 to 24 hours. If the foreign body, suppose a large coin, has not moved beyond the stomach, we realize that it is unlikely to move anymore, because it takes 4 to 6 hours to 8 hours for something to move beyond the stomach into the intestine. So it is almost 12 hours, 24 hours, and it has not moved. But the child is asymptomatic. Still, we would go in with an endoscope and remove it, because the endoscope is successful in removing foreign bodies from the esophagus, which is the food pipe, from the stomach, and just beyond the stomach from the early part of the small intestine, beyond which our endoscopes do not go. Beyond which, if the foreign body goes and the child is asymptomatic, then we monitor the child with serial X-rays. If it is coming down, then no problem. We will tell the parents to look at the stool every day, and if it passes in stool, well and good. If it doesn't pass in the stool, we will get serial X-rays, and if it doesn't move, then we call in the surgeons. We might have to remove it surgically, or if it gets stuck in the IC valve or the ileocecal valve, it is a difficult procedure, but we can attempt removal with a colonoscope too. So hopefully you enjoyed this session of discussion of foreign bodies in children. Just to inform you, we have the full set of accessories and equipment and the personnel needed for foreign body removal in children at Bhagirathi Neotia Women and Child Care Center at Newtown, and we are at your service. God forbid if your child needs such a procedure. So I will just show you some examples of foreign bodies in children. So this figure number 1 shows a coin which has been ingested by the child, and it is stuck in the upper part of the esophagus. The figure number 2 shows the multiple things that children often ingest, and as we were discussing. Figure number 3 is a foreign body, again a coin which is stuck in the mid-esophagus. So we can see it in the X-rays. Foreign body is stuck in the mid-esophagus. In figure number 4, we see a foreign body which is stuck at the outlet of the stomach. So this again can be taken out by endoscopy. In figure number 5, you see this is a sharp object which is in the intestine, and this child actually needed operative removal because it did not come out. and that was the picture of the operation, which is showing it, which shows it is being removed by operation. So figure number 7 shows a foreign body which has almost come down, and it is in the lower part of the colon, and in such a situation it is most likely to come out through the stool. Figure number 8 just shows a picture of a coin being removed, and this is being removed with the help of alligator forceps. And figure number 9 shows a rock net, which is a very useful instrument, accessory for the removal of foreign bodies. Figure number 10 shows the multiple photos of multiple foreign bodies which children ingest, and though it often looks like a coin, there is a halo sign in these button batteries, which differentiates button batteries from coins, and that indicates a case of an urgent removal. And the last 4 figures show unfortunately, a button battery was impacted in the esophagus, and it has caused a burn, it has caused a scar, and it was removed, which is shown in the last figure in this set of figures. Thank you.